طيب، بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيد الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. اللهم لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا ما علمتنا وزدنا علما. My name is Tariq Nasir, consultant in endocrinology and chair of Department of Medicine, King Abdulaziz Medical City, Jeddah, Ministry of National Guard. I would like to start with thanking the organizing committee, especially Prof. Abdurrahman al-Sheikh and Dr. Yusuf, Dr. Saud al-Sifri, and Aspire, Mr. Majid and his colleagues for the wonderful organization and wonderful meeting. It is my pleasure to moderate the first session in the second day, today, Wednesday, 24th of June 2020. In this session, we'll have, inshallah, 4 eminent speakers with 4 presentation. Inshallah, we'll enjoy the presentation. The first presentation will be by Dr. Khalid Al-Amri. Dr. Khalid Al-Amri, consultant of obesity, medicine, and metabolic disorders. He's a consultant of family medicine, chairman of obesity department, King Fahd Medical City, obesity, endocrinology, and metabolism center, Riyadh, Saudi Arabia. He has fellowship at Imperial College University, London, UK. And he's going to talk about what makes obesity. Please, Dr. Khalid, the floor is for you.
Thank you, Dr. Tariq. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you for everybody to be with us for tonight. And that would be my pleasure to have this presentation about obesity, a title, What Makes Obesity. Everybody can actually please mute the sound, and please you can write down the notes or the questions. The objectives of my presentation tonight mainly will focus on 3 things, like the definition of obesity and how obesity became now a major problem and increasing recently to become a huge medical condition that burden the healthcare system everywhere. And we will talk about the causes. We'll take some different aspects, and we will highlight on some points about the causes of obesity. Then we will end up with the conclusion. Sharma saying obesity is a heterogeneous complex disorder and has a multiple etiology or multiple causes that can cause excess body fat, and this body fat definitely will cause medical problems, physical health problems, also mental complications and socio-economical complications. The most comprehensive definition for obesity is not only a BMI or not only increase in the body fat, but it's it's a chronic relapsing disease. And in the Obesity Medicine Association, they are telling it is a neurobehavioral disease where there is an increase in the body fat that can cause a lot of health consequences, biomedical, metabolic, psychological, social health consequences. So it's like an umbrella of many other health problems or diseases. This is from the WHO. You can see that the prevalence of obesity or people with BMI more than 30, not exceeding 10% in most of the countries in the world. But in the 2014, most of the countries exceeding 20 and 25% from their population with a BMI more than 30. And you can see the Gulf countries and also the North America affected with the highest number of obesity with a BMI exceeding 30%. And the one who is following the curve of the BMI in Saudi Arabia, seeing that the problem is increasing with the time and going up without any plateau effect or decreasing until the time. And we do expect in 2025 to reach 40% of the Saudi population affected with obesity, I mean a BMI more than 30. So it is a disease. And why it is a disease? Because all the characteristics of the disease are there available in obesity. So it has an impairment of the function, it has signs and symptoms, and can cause harm or even morbidity. So we can consider a disease, and this is what most of healthcare organizations and bodies and institutions admit, that obesity is a disease, not only disease, but chronic disease with the multiple relapses. So if we're coming to the point, what makes obesity, I think everybody knows that obesity is secondary to many things, but if we can classify the situations, we can see that there are some factors like environmental, cultural, biological, psychological, and all of these factors integrated together, or it has some sort of association or integration to be reflected on changes in the behavior. And this behavior would be the things that is obvious to all of us, either hunger and overeating or sedentary lifestyle. And if we would like to be more scientific in classifying what would be the cause of obesity, the most important things is under the cortex area in the brain, in the hypothalamus exactly, and in the arcuate nucleus in the mesolimbic area. These are the center that controlling our appetite and satiety and the hunger feeling. Definitely, we have a lot of signals coming from different parts of internal and external, but the control area will be in the brain, in the center of the appetite. So energy intake. So if we would like to talk simply energy intake and energy expenditure, so this balance, if there is imbalance between them, so I mean energy intake more than energy expenditure, definitely we will end up with obesity. And now we will talk about some things, and definitely the topic is a huge, and we cannot tell everything in 20 minutes, but I would like to highlight about some things. It might be beneficial to all of us, and at least in our clinical practice. We know the type of food, and type of food at the moment is something, recently the food became, the unhealthy food became, the processed, the commercial, high in sugar and fat. This type of food became available more and more and became accessible and even cheaper and easy to prepare. And this is one of the things that play a role in increasing in obesity. So our type of food, the unhealthy food, now became accessible to everybody, convenient, easy to prepare, inexpensive. So this is one of the factors that we should highlight on this factor. Not only the type of the food, but also the portion size. The portion size, it has a major role in how much calorie we are intaking. As you can see from this clinical trial, as we increasing the portion or the size of the food, so you do expect that the participant will eat more calories. In this trial, they gave 4 different types of sandwiches with definitely different calories. As the size increased, so the calories increasing. The participants at the end of the trial, they gave the same feeling, the same rate of satiety and the hunger, but most of them, they ate the huge, or the all sandwich. So giving large portions or advertising for large portions, especially if it is unhealthy food, you do expect to give more calories, and this is one of the causes that we should think about when we are dealing with obesity. What about the psychological factors? There are a lot of studies and data done on that, and there is a big relationship, obvious relationship between the psychological factors and the obesity. You can see in this survey done on around 9,000 or more than 9,000 survey done on uh, mental health center, and they asked people with mood disorder, and they found as the BMI increasing, so you do expect that there is he will be affected with some sort of mood disorder. As we can see, we found that the major depression, mood disorder, dysthymia, even mania and hypomania increasing as the BMI increased. And if the BMI in overweight or normal weight is less likely to have a mood disorder. What about the anxiety disorder? Same thing. They have found different type of anxiety disorder in the favor of increasing in the BMI. So overweight and obesity as well has a relationship or correlated to an anxiety disorder. Is the anxiety disorder causing obesity or obesity causing an anxiety disorder? Actually, it is a bidirectional relationship. In this meta-analysis that have been done in reviewing more than 9 trials, they found the obesity with the BMI more than 30 here in the left side. They found the first plot at the end of the meta-analysis in the favor of increasing depression with increasing in the BMI. But in the overweight, they did not find it significant. So as the BMI increasing, especially more than 30, we do expect mood disorder or even depression. So we need to ask our patients or to screen them at least for such problem. So this meta-analysis, it shows that as the BMI increasing, so you do expect the odds ratio will be 1.5, so 1.5 time increase in the risk of developing depression at the onset of the follow-up of obesity. We will come to the another part of causes of obesity, which is the energy expenditure. And energy expenditure has many things that we can talk about, but we will see that recently as our food became unhealthy more and commercial more, at the same time the physical activities reduced significantly. That's because either there is no place for the physical activities, the sidewalk are very low, and the educations about the importance of that is reduced, and also maybe because of the technological effect on our life. Now, a lot of people using the technology in the daily life and using the internet and using the game, the video games and the social media, all of these things in decreasing the level of physical activity, and it has an impact on increasing the number of obesity. The age and gender, there is differences between us in terms of the age, as you can see from this curve. As our age increasing, so we do expect decrease in the basal metabolic rate, so increasing in the chance of developing obesity. And if you compare the different genders, we know that the male has a more chance for more basal metabolic rate more than the girls. So this is usually the differences, especially if they exceeded 5 years old. So expect basal metabolic rate more in the male and less as we are aging with the time. Another factor is the sleep deprivation and the sleep pattern. And you can see from this survey done in between the 1982 and 1984, people sleeping less or fewer hours, you do expect to have a higher BMI. So as the time or the hours of the sleep during the night increasing, so you do expect decreasing in the BMI. So it is a very important aspect that you need to highlight when you are talking with your patients. And you can see from this clinical trial that have been on a little bit small, I mean sample, 12 participants in a crossover matter clinical trial, they found that if there is a deprivation, I mean decrease in the number of hours in the bed for two nights, there will be an increase in the chance of appetite. And if there is increase in the number of hours during the sleep per two consecutive nights, so there will be decrease in the level of the appetite. And that may be secondary to decrease in the level of the leptin and increase the level in the ghrelin with the patients not sleeping very well or sleeping low during the night. Other miscellaneous things is the like genetics or medications or some infections. We know, as we said at the beginning of this lecture, that we have a center controlling our appetite in the brain, in the hypothalamus, where the signals coming, for example, from the leptin or any other hormones, going to two different pathways, either POMC to suppress appetite or NBY oxidate receptors to increase the appetite. So usually the satiety hormones like the leptin or GLP-1 or other hormones going to the POMC neurons and firing this one to secrete alpha melanocyte stimulating hormone and beta melanocyte stimulating hormone going to the MC4 receptors. And if the MC4 receptors, the gene responsible about this receptors is intact, there is no mutations or syndromatic effect, so it will work effectively by decreasing the food intake and increasing in the energy expenditures. Also, we have a polygenetics rule in the development of obesity. And there are too many types of genes related to different type of races and genders responsible and representing sort of function in controlling our appetite and either increasing the appetite or decreasing the appetite. So there was a great progress in the genetic and epigenetics study and works. And if we can know the relationship between the genetics and the environment factors and making like a pathway or guideline between our genes and the environmental factors, I think we can understand this disease and we can find proper, applicable, and successful treatment for obesity. Drugs, we know that reviewing the drugs that patient taking is very important, and sometimes avoiding the drugs that might cause increase in body weight, it might help in controlling this situation and helping the patient to lose weight. We know that the psychotropic medications has a big list of medications that can cause weight gain, and shifting from these medications like antipsychotic olanzapine or amitriptyline or SSRI medications to some medication with less effect on appetite might be beneficial in controlling the appetite. We know that most of the diabetic medication, or not most of the diabetic medication, the sulfonylurea medication and TZDs and insulin, we know that it's correlated with increase in the body weight. So shifting to the neutral agent or some medication that decrease body weight will be a good option. We know the glucocorticoids, sometimes patients taking the medications for unnecessary reasons can cause weight gain, and other agent is oral contraceptive. What about the infections? There are a lot of research now going on to find a relationship between the infection or risk of certain infections or viruses that might cause obesity. And this trial is, this study collecting from different trials or studies done on animals or observational studies on human, they found that the adenovirus correlated positively with increase in the visceral adipose tissue and causing obesity. So infection might play a role even in the development of obesity. So you can see that obesity is not appetite or not moving or doing exercise. It's like environmental factors, behavioral patterns, genetics background, all like having a relationship and like interactions between all of these aspects. And if we understand the effect of each item and how we can control each item, it might help us in controlling obesity or at least finding a successful treatment, even adding like policy interventions or providing like area or for practicing, for example, physical activities or trying to prevent unhealthy food, it might have a good input in preventing further increasing in this problem. So in a summary, obesity is a chronic relapsing disease, and it is globally increasing everywhere, not only in our area. And if we can talk simply, it is imbalance between energy intake and energy expenditure, but there are a lot of things behind taking more energy and losing less energy. And we need to studying the relationship between the genetic and other environmental factors that might help us to find solutions or a proper treatment for the obesity. And during our assessment of obesity, we need comprehensive, we need to involve all of these aspects, including environmental, lifestyle, type of food, behavioral during eatings, other, if we can, genetics background, the drug medications that he's taking to find the way or the best treatment for the patient. And thank you so much.
Thank you, Dr. Khalid, for this excellent review. Thank you for restricting to the time. We'll leave the question for the end of the session. And now we'll go to the second presentation by Dr. Hussein Al-Gurani. Dr. Hussein Al-Gurani is a consultant endocrinology at Al Musa Specialist Hospital. He had the American Board in Internal Medicine, Endocrinology, and Obesity Medicine. And he's the program director of Internal Medicine Residency Program at Al Musa Specialized Hospital. And he's going to talk about obesity. His presentation is titled as Obesity More Than a Weight Problem. Please, Dr. Hussein, the floor is for you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the organizers committee and for Mr. Chairman for the kind introduction. Let me pull my slides. All right, so my talk will be about obesity more than a weight problem. And my objectives for this talk would be to highlight the importance of treating obesity as a disease, and then review the linkage between obesity and its associated comorbidities. So first, I would like to thank Dr. Khalid because I will build my talk upon his presentation. He did a very nice job explaining the multifactorial aspect of obesity. So as you all know, obesity now is recognized as a disease and a huge public health crisis by almost all the major health organizations, including American Medical Association, FDA, EMA, and many others. And this is very important for us because this would push for policies, research, and also shed some light and awareness about obesity as a disease. So Dr. Khalid already explained this very nicely, that obesity is considered a disease because it meets the definition of a disease. It is associated with a physiologic and metabolic dysfunction. It has clear signs and symptoms, and then it results in morbidity and mortality. Now, this morbidity and mortality is related to the physical increase in fat mass itself, and also to the physiologic and metabolic derangement that's part of obesity itself. So classically, when we discuss body weight regulation or obesity, we always present the first law of thermodynamics, and everyone is familiar with this. So basically, calories in equal calories out to maintain a stable body weight. So for someone to gain weight, they either have to have more calorie intake or less calorie output, and vice versa if they want to lose weight. And hence comes the famous advice: if you want to lose weight, it's easy, just eat less and move more. And we know this is not really as simple as this. Our patients know this as well. Everyone who struggled with obesity or treated obesity knows this is not as simple as that. Why? Because obesity is a really complicated multifactorial disease. Dr. Khalid already alluded to the multiple aspects of this. So there are factors inside the person, factors outside the person in the environment that's beyond the person control. We have genetic factors, epigenetic factors, and a real pathophysiology that fights to keep a high set point to maintain a higher body weight. I want to spend more time on this on this diagram. So this is basically the central nervous system homeostasis of body weight. So here we have peripheral signals coming from peripheral tissues like adipocytes, including leptin, insulin from the pancreas, and then multiple GI peptides like ghrelin, PYY, and GLP-1, many others. These signals are relayed to the hypothalamus in the arcuate nucleus and integrated. We have two different sets of neurons. We have the anorexic neurons that have POMC, CART, and then orexigenic that promotes weight. That's AGRP, NPY neurons. And activation of these neurons would then result in downstream actions, including regulated behavior or a change in resting metabolic expenditure. So therefore, the weight regulation is centrally regulated in humans. And so from here, I want to present two important concepts that answer the question, why is it hard for patients, for people in general, to lose weight and keep it off? And the two concepts here are hypothalamic injury and hormonal or metabolic adaptation. So this is the first concept of hypothalamic injury, and this is based on the work of Dr. Michael Schwartz in Seattle. Very elegant work, actually. So here they bring rodents to study obesity, and they induce obesity by high-fat diet. And what they observe after they sacrifice the animals is that there is hypothalamic inflammation that interestingly occurs within days of high-fat diet onset. And then within a week, you would see reactive gliosis and more markers of inflammation and injury in the hypothalamus and the arcuate nucleus of rats and mice. Is this only in animals? What about humans? So they went one step further, and they looked at brain MRIs of patients with obesity and patients with normal body weight. And they identified also increased gliosis in the hypothalamus of patients with obesity when this was assessed by MRI. So these findings together from the animal section studies and the human MRI studies suggest that obesity is associated with neuronal injury in the brain, in the part that's crucial for body control, both in humans and in animals. So that's the concept number one. So back to the same diagram. Think of the central area in our brains that control weight, and that there is ongoing inflammation, gliosis, that affects signal transduction, neurotransmission, and therefore the perception of patients of appetite and hunger, and therefore their behavior when it comes to eating. So that's concept number one. And the other concept basically was also beautifully demonstrated in this paper that was published in the New England Journal of Medicine in 2011 about the hormonal adaptation that occur with body weight loss. So in this experiment, what they did, they brought subjects who are either overweight or obese, and they put them through an intensive weight loss program, 10-week program. So they put them on very low energy diet, 500 to 550. And then they measured some markers, hormones at week 0, at week 10, at the end of the program, and then a week later. They were followed for up to 1 year. So this shows the how much weight they lost. So on average, after 10 weeks, they lost about 13.5 kilos. And then 1 year later, they gained back 5.5 kilos, which is typical of what we see with many interventions. There's initial weight loss and then some rebound weight gain. So ultimately, on average, they lost about 7 kilos. So what happened to their hormones and that are involved in appetite regulation? So here you can see this is ghrelin. Everyone knows ghrelin is a hunger hormone that promotes eating. And you can see at baseline, it was here at this level. At 10 weeks, with the maximum weight loss, it went very high up. And then at 1 year later, it still remains elevated from baseline. What about the satiety hormones like amylin, PYY, and CCK? Again, their levels basically were lower at 10 weeks when they achieved the maximum weight loss, and they remained below baseline even 1 year later. So what is the implication of this? Our patients, once they lose weight, they continue to fight their own biology, their own hormones that tries to drive back the higher body weight by basically affecting their choice of food, how much they eat, etc. So the point of these two concepts that there is a significant biological factor that drives higher body weight, which makes it more difficult for our patients to lose weight and sustain that weight loss. Now, the second part of my talk will be about obesity complications or comorbidities. So we know we have more than 200 conditions that are either caused directly by obesity or exacerbated by obesity or excess adiposity. And we can divide these complications into many categories. So we could say we have metabolic complications. Most of us are familiar with those complications. We have NAFLD, which is becoming a huge reason for liver transplant now, gallstone infertility. And then we have the cardiovascular risk factors: stroke, hypertension, coronary artery disease, pulmonary embolism, dyslipidemia. Type 2 diabetes, there's a very well-established relationship between weight and diabetes, prediabetes, thrombosis, and gout. But then we have the mechanical complications because of the sheer volume of the adipose tissue. So this affects physical functioning, asthma, incontinence, osteoarthritis, sleep apnea, and chronic back pain. And then lastly, we don't forget about the mental component or mental complications: depression, anxiety. And Dr. Khalid already alluded that the relationship between depression and anxiety and obesity is bidirectional. So patients with obesity have higher risk of depression and anxiety, and those with depression and anxiety have higher risk of having a higher body weight. Now, if you look here, you would see that with the exception for dyslipidemia, there is a very linear relationship between body mass and these obesity-related complications, including ischemic heart disease, hypertension, type 2 diabetes, gallbladder disease, arthritis, sleep apnea, and NAFLD. And we also don't forget about COVID. We are still fighting COVID-19. So this is from the CDC data, and obesity was the most prevalent comorbidity among patients who were less than 65 years of age with COVID-19. So obesity also impairs our immune function and results in higher risk of infections. Now, I will try and shed light on some specific problems that are not typically thought of as related to obesity, starting with some cardiovascular complications. So heart failure and atrial fibrillation. So an analysis from the Framingham heart study, they followed 6,000 individuals without history of heart failure for a mean of 14 years. And there they found the risk of heart failure to be increased twofold in subjects with obesity compared to those with normal body subjects. And then when they adjusted for the classical risk factors for heart failure like hypertension, ischemic heart disease, diabetes, this risk for heart failure still remains 5% higher in men and 7% in women for each increment of 1 unit in body mass index. So obesity is an independent risk factor for heart failure, even without the presence of ischemic heart disease. So keep this in mind when you evaluate a patient with obesity. Here in this figure, you would see, again, the linear relationship of different categories of body weight, comparing normal subjects, overweight and obese, both men and women, and how obesity correlates with a higher risk of heart failure. The second part is atrial fibrillation. And again, there is evidence of increased risk of atrial fibrillation in the setting of obesity. This is probably because of left atrial remodeling via various mechanisms. And in this study, the ERIC study, it was estimated that at least 1 in 5 cases of AFib is attributed to obesity. And this is a brief description of the multiple mechanisms involved in between body weight, obesity, and atrial fibrillation. And it involves mechanical factors, hemodynamic factors, inflammatory factors, and then metabolic and neurohormonal, ultimately resulting in left atrial remodeling, fibrosis, fatty infiltration, ultimately affecting the conduction system, and therefore increase the risk of development of atrial fibrillation. What about cancer? So excess weight is associated with increased risk of multiple types of cancer. And according to the CDC, up to 40% of all cancers in the US in 2014 were caused by obesity. That's a significant number of cancers. What is the mechanism for this? There is multiple theories about why patients with higher body mass have higher risk of cancer. That includes alteration in sex hormone metabolism. We know adipose tissue has more aromatization of testosterone to estradiol that drives some of the hormone-sensitive cancers, and then insulin and insulin-like growth factor levels and adipokines. So let's take this example of this target cell, which could be a precancerous cell, which expresses insulin receptor, IGF-1 receptor as well. So patients with excess body weight have higher insulin and higher IGF-1, which drives then mitogenic anti-apoptotic activity and their increased cell proliferation and therefore increased risk of tumor development. That's one of the models that's suggested to explain the increased risk of cancer. So again, this is from the CDC, and here they demonstrate that overweight and obesity is associated with 13 different kinds of cancer. However, a more recent analysis, this is from Imperial College of London, umbrella review of multiple systematic reviews and systematic analyses. And they reviewed all the evidence, and they established that there is very strong evidence correlating body BMI with these cancers: esophageal adenocarcinoma, multiple myeloma, gastric cancer, colorectal cancer, biliary cancer, pancreas, breast, endometrium, ovarian, and kidney cancer. And then what about psychiatric complications? So again, this is very well established that patients with obesity have impairment in both physical and mental health-related quality of life. And depression is associated with severe obesity, especially in younger patients and in women compared to men. What about dementia? So again, obesity has been shown to be a risk factor for dementia, independent of other comorbidities that increase the risk of dementia. In this study that was carried for 27 years and followed patients, more than 10,000 subjects with obesity, they noted there is a 74% increase for those with obesity and 35% increase in dementia for those who are overweight as compared to normal weight. So it's not just obesity, even being overweight carries a higher risk of dementia. And we shouldn't forget about obesity stigma. So patients with obesity are exposed to public disapproval because of their weight. In the mind of the public, obesity is the fault of the patient, and therefore they blame the patient for it, and it's seen as a poor and a flaw in the character of the personality of those patients. So there is stigma that's seen in education, employment, and in the healthcare setting. And this is unfortunate that even healthcare providers, they have their own bias and stigma against patients who have higher body weight. In employment, candidates who apply for jobs who have obesity are viewed as less suitable compared to those with normal weight candidates. And this discrimination toward patients with obesity is higher in those jobs that's more physically demanding. So in summary, obesity is a complex chronic relapsing condition that's a result of multiple factors, including genetic, metabolic, environmental, and behavioral. And it's associated with increase in both morbidity and mortality. Relapse after weight loss has pathophysiologic basis. So it's not simply the patient falls or lack of will. And this includes hypothalamic injury and metabolic adaptation. And then finally, excess weight correlates with many complications, including metabolic, mechanical, and mental complications. Thank you very much.
Thank you very much, Dr. Al-Garani, for this interest and excellent review. And thank you for respect to the time. Our third presenter will be Prof. Asim Al-Fida. Prof. Asim Al-Fida is Professor of Medicine, Endocrinology, and Metabolism, Chairman of Department of Medicine, Director Obesity Center Research, Obesity Research Center, Director Strategic Center of Diabetes Research, College of Medicine, King Saud University, and he's going to talk about scope of managing obesity. Please, Prof. Asim, the floor is for you.
Thank you, Dr. Tariq. Happy to be with you and with colleagues tonight to discuss an interesting topic on obesity. I hope you can see the slides now. Okay, so what I'm going to talk about tonight is the Action-IO study, which highlights the gaps that we have in managing patients with obesity. Action-IO stands for Awareness, Care, Treatment in Obesity Management, and International Observation. It's a study that has been done in 11 countries worldwide. These are my disclosures. So in order to manage obesity, we need to know what are the barriers we are having. And as the previous speakers clearly mentioned that this disease is still not under control and it's spreading worldwide with all its complications. So what is going really on in preventing this from increasing and why we are failing in controlling this disease still need to be determined, and we need to have an action plan on this. That's why this study tried to get or to understand the problem of obesity from the perspective of people with obesity and the healthcare professionals. So the Action study has been conducted before in the United States and in Canada. The third one was the international observation, which was done in 11 countries worldwide. With the primary study objective was to identify perceptions, attitudes, behaviors, and potential barriers to effective obesity care across people with obesity and healthcare professionals. There are also secondary study objectives, which is to generate insights to guide collaboration and to collaborative action to improve the care and education and support for those suffering from obesity, and to create a communication platform to help change how patients and healthcare professionals manage, treat, and support patients with obesity. More than 14,000 patients with obesity and more than 2,700 healthcare professionals had been surveyed, and the main data has been published in 2019, which is available online. I'm going to be specific tonight to talk about the data in Saudi Arabia, and this is the national publication group that is working on publishing the first paper from Saudi Arabia. And to give you a quick overview about the methodology of the study, it is basically a survey which has been distributed for people with obesity and HCPs. In case of Saudi Arabia, it has been face-to-face discussion and interviews to get the information after doing a quick pretest to make sure that all the questions are clear to the participants. And then the data has been analyzed and published within the international data. And then recently we are submitting, inshallah, the Saudi Arabia data. So the survey response rate was 57% in people with obesity and 36% in HCPs. You can see that most of the patients with obesity were having class 1, and almost 30% had the class 2, only few had the class 3 or more. On the healthcare professionals, most were either an internal medicine specialist, endocrinologist, gastroenterologist, and obstetric and gynecologist, and also primary care physicians. So this is the distribution of the HCP studied. 50% primary care physicians and 50% specialized physicians. So the primary results, I will summarize it in three important points. The first about the attitude towards obesity, The second is the past attempts at weight loss. And the third is the weight management conversation. And this is all mainly on the Saudi data. Just to give you an overview about the perception of obesity as a disease internationally, about 2/3 of people with obesity agree that obesity is a chronic disease. And about 88% of HCPs agree that obesity is a disease. Comparing this to the Saudi data, we have almost the same exactly number of people with obesity. 2/3 agree it is a disease, but surprisingly, only about 2/3 of healthcare professionals in Saudi Arabia who have been surveyed in the study agree with this diagnosis. So the first thing we notice here is a gap in the perceiving obesity as a disease, which will lead to problem in or delay in diagnosing and treating this disease. So also we can notice that there is a gap in understanding the effectiveness and the benefit of losing about 5 to 10% of body weight. Although most of the patients with obesity in the study agree that weight loss of 5 to 10% was beneficial, only 63% of the HCPs think that this weight loss will be of benefit to the patient. Again, a gap that need to be further discussed and more education need to be done in this point. The third point in the attitudes toward obesity, you can see in the slide that most of the questions that were asked to the people with obesity about their motivation, are you motivated to lose weight? Surprisingly, you can see that good number of them did answer yes, I am motivated to lose weight, though they are saying that this weight problem is their own problem, and this is completely their responsibility, which make the burden on them higher than what it should be. And this will explain the results I'm going to show you later on, inshallah, about the outcome of this weight loss that they are trying to do by themselves. So they agree that the obesity is a problem, it's completely their responsibility, and they can do something about it, and 50% were motivated to lose weight. Moving to the second part of the results is the past attempts at weight loss. So about 92% of people with obesity have made at least one serious weight loss attempt. 61% had 1 to 4 attempts. So they are trying to lose weight. But surprisingly, when you come and see the result of these attempts, you can see that about 61% only had lost 5% or more of their body weight. And after 1 year, only 5% could maintain this weight loss. And this highlights what the previous speaker, Dr. Hussein, mentioned about the problem of weight regain, and we are dealing with a disease rather than a lifestyle problem. Again, when you go and see the 10% weight loss, the numbers are even striking more. 25% had lost weight 10% or more, and then only 3% of them maintain this weight loss, which is again tell you there is something or there is an issue on maintaining the weight loss. The third part of the results is about weight management conversation. So what do we expect of the conversation that take place between the HCPs and people with obesity? Interestingly, you can see that we had studied 1,000 patients with obesity, and only about 57% of them had a discussion with their healthcare professionals. So we are losing already about 50% of the patients because we are not talking to our patients, or our patients is not talking to us. It's both ways about this problem. And then we are even lower after we talk to the patients to diagnose the problem as a disease and to have a further follow-up. So we are losing a lot of cases because of this lack of communication, lack of awareness about the disease, and lack of taking active measures to treat the disease. And the other thing which we had noticed also is that after the patient is struggling with the disease, with the mean age in the Saudi study was about 27 years, they will start to struggle with their weight. Only after 6 years, they will have the first discussion with their HCP about the problem. So there is a gap of 6 years between the problem itself and asking somebody to help with this problem. This year's, well, as you know, as we hear from previous speakers, clearly that this year's could already had complications started, and also this might affect the long-term outcome of our treatment, because we might not be able to reverse all these complications that already started in these 6 years. So again, when you ask the patient about did you discuss your weight in the last 5 years with your HCP, only 58% had a discussion in the last 5 years. So we have clearly a gap of discussion between the patient and the healthcare professionals. And if there is no discussion, there is no diagnosis. If there is no diagnosis, there is no direction or action on the case. Again, when you ask the HCPs how many patients have you discussed obesity with in the last time, in the last year, you can see that only 61% had discussed the weight with their patients. Now, what is the problem? Is it the patient not talking to the physician about the problem, or is it the physician not initiating the discussion? And you can see here, interestingly, that patients think that I did start the conversation in 70% of the time. The physician only started it in 30% of the time. But the HCP said, no, I did start the conversation most of the time. Patient only started the conversation in about 1/3 of the time. So again, contradicting results was showing a gap in our understanding of this problem. So, but when you ask those who did not discuss the problem with their physician, would you like this to have been discussed during the visit? 63% yes. They were expecting, or they were hoping that this weight problem was discussed with the physician during the visit. So still, they would like somebody to talk to them about this. And after the discussion occurred, most of the patients would feel positive about it. I think the discussion was helpful. They were relieved, motivated, supported by the HCP. Few of them think negative about the discussion, maybe because of the time. There was rushed. The physician did not have enough time to discuss it with the patient. And interestingly, only very, very few had or think that they are offended by this discussion. So again, we have an important opportunity here. If we can target this point of improving the discussion between physicians and patients about the weight problem, we will be able to achieve a lot in our battle against obesity. This is also the reason of not discussing the weight. So if you did not discuss the weight, what was the problem from the patient perspective, from the HCP? And interestingly here, we can see that most of the healthcare professionals think that patient is not interested in losing weight. So they have this idea that the patient is not interested in losing weight, therefore I'm not going to discuss the weight problem with the patient. But when you ask the patient themselves, only 25% think that this is the reason they are not discussing the weight with the HCP, because they are not interested. So again, a gap of what about 40% of patients that we are missing, just because the physician think that, okay, I don't think that the patient would like me to discuss this. Maybe they are not motivated. They don't want to lose weight, and they don't start the discussion. What make the physician start the discussion with the patient? Most of the cases, it's either the BMI that they notice it's elevated, or there's any comorbidities, which also point towards a late discussion in the scale of this disease, and delaying getting any action as soon as possible. To whom the patients usually go and to discuss this problem, you can see that about 1/3 is being discussed with physicians who specialize in nutrition, primary care physicians, 32%. Interestingly, which we did not observe in other countries' data is that about 29% of our patients in Saudi Arabia discussed directly, or the first point of contact was with dietitian and nutritionist, which give us a big opportunity to work on this and to make sure that we continue the discussion in these clinics and take proper action in treatment and follow-up. And these are the other specialties that the patient would discuss their weight with according to this data. So also an interesting thing that we found is that, okay, what do you think would be an effective method for long-term weight management? Would you think it's the lifestyle that will be effective? Is it the medication? Is it the surgery? What do you think would be effective to keep you maintaining your weight loss for a long time? These are the HCPs and the patient with obesity, and you can see that general improvement in eating habits. About 71% of patients think this is very important or is an effective method to weight loss and maintain weight loss. And then specific diet. When you go to medication, over-the-counter medication, patients 85% think this is an effective way, which will make us a little bit worried because we don't know exactly what medication they are using and if this is approved or not by the Saudi FDA. So we need to make sure that they are not taking medication that would harm them instead of benefiting them. Or benefit them. And also what is interesting is that visiting a nutritionist, 91% of patients think this is an effective way, which is almost the same as visiting a bariatric surgeon, which also makes us think twice about the utilization of our dietitian and nutritionist clinic in facing this problem in our society. So to wrap up here, we know that many patients with obesity are concerned about this disease. They think it's their own responsibility to treat it, and that's why they are making a lot of attempts to get successful outcome. However, they are not they have no good success on these outcomes. On the other side, healthcare professionals believe that people with obesity are not interested or motivated to lose weight, and this may be a key barrier in our obesity management, and that we should make sure that we close this gap. Again, the gap of delaying the discussion of 6 years, so something that is not good, and we need to make sure that this gap is not that long. And interestingly, internationally, we have the same figure, about 6 years in the countries we studied between the problem of weight and the first discussion with an HCP. So please understand that most people of obesity here, according to the data here, would like to do something. They are interested to do it, and they would like the discussion to start in the clinic visit with their physician. For the physician side, we need to improve the education on the biological basis of obesity and the problem of weight regain. It is not basically or just mainly that the patient is not eating good food. It's the physiology, the hormonal changes that occur after weight loss. It's a chronic progressive disease. We need to improve also the education on this part and what are the available measures in terms of diet, exercise, medication, surgery that are available for the healthcare professional to utilize in treating patients with obesity. And again, follow-up is very important also to make sure that patients do stick to the plan. So this summary this will summarize my talk, is that we are focusing mainly on the 3D approach. And I think this is something peculiar that Action.io came with: discussion, diagnosis, and direction. So discussion, start the discussion with your patient as soon as you can about the disease, about the problem of the weight. Diagnose the disease as obesity, diagnose obesity as a disease, and then do the direction on that. Take action, treat the patient, refer them to a specialist, give them follow-up. So discussion, diagnosis, direction is the 3D approach that we need to utilize in facing the problem of obesity in our society. With this, I'd like to thank you for your listening, and can answer some questions at the end of the session. Thank you.
Thank you, Prof. Hazem, for this excellent and very nice presentation. Now we'll go to the last presentation by Dr. Nabil Najjar. Dr. Nabil Najjar is consultant diabetologist and endocrinologist. He's a fellow of the American College of Endocrine, head of diabetes and endocrine center at Hayya Al-Jama Hospital, Jeddah, and he's the president of Jeddah Diabetes Club, and he's the president of the Jeddah Hypertension Atherosclerosis Club, and he's a member in a number of international society, and he's going to talk about new insight on ultra-long insulins. Please, Dr. Nabil, the floor is for you.
بسم الله الرحمن الرحيم والصلاة والسلام على خاتم المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. It's very interesting to start an issue of insulin in a session of obesity. However, the link is still there, and we know by science and experience that insulin is one of the causes of increasing weight in patients who are heavily treated with insulin. Maybe this is one of the causes of why we included that in that session. These are my credentials, and we are going to speak about the insights on the ultra-long basal insulins. And to start with, we know all the guidelines of the ACE regarding the when to start the basal insulin. And if we were going to choose among these four options here, as you can see, I think the first option is the right one. The ACE starts to advises to start basal insulin if A1C over 7.5%, on condition that it will be associated with signs of catabolism. And this means weight loss or any other sign of severe insulin deficiency, even at that level of A1C. And as you can see here, in this algorithm of treatment of the patients, this is the dual therapy after failure of a monotherapy. And you can see that basal insulin is there here, together with metformin and any other oral drug. So in the ACE guidelines, you are allowed to use basal insulin as early as the A1C is just 7.5 or more. And again, in the American Diabetes Association guidelines for 2020, they have stated that the yearly introduction of insulin should be considered if there is evidence of ongoing catabolism, demarcated by weight loss, for example, or there is a severe symptoms of hyperglycemia present at the presentation. And again, if the A1C level is above 10. However, this also concludes the use that of insulin at early phases more than 7.5. In fact, the basal insulin is the first step in giving insulin to patients with diabetes after failure of oral therapy. And if you choose to give the patients insulin, you are going to start with basal insulin. And this is the advice of all the guidelines all over the globe. And looking at the evolution and innovations of basal insulin, and we know that the first insulin was discovered in 1922. And this was an extract of pancreas. Then an NPH came after 25 years, which was an innovation at that time. Then after 30 years, we have a great innovation, which is a human insulin that is less immunogenic, more profile of action, more better pharmacodynamics and pharmacokinetics, and we started not to use the insulin of big origin. Then we have taken another 20 years to have the first insulin analog, the fast-acting insulin. And very rapidly after that, 4 years, we have the first long-acting insulin, which is the Glargine, 100 milligrams, 100 units. And it have taken 12 years more to have another innovation in the basal insulin, which is the degludec insulin. Again, after 1 year only of the announcement of the degludec, the Glargine 300, which is 2GU, have been launched and have shown a very nice results, both in efficacy and safety. This is the evolution of the business. What are the requirements of an ideal basal insulin? The ideal basal insulin should be stable with prolonged pharmacokinetics and provide pharmacodynamics profile. They shouldn't have a peak. They should mimic the original human insulin secretion in the basal state, where it is continuously on the same level over 24 hours without peaks. However, as we are speaking in an obesity session, it should be weight neutral. That means that it shouldn't increase the weight so much for this patient, leading to complications. Again, it should prove that it have a long-term safety as regards hypoglycemia. And again, it should be flexible use. And it should be available and offerable all over 24 hours for the patient as regards the timing of the doses and how to do with the missed doses. This is the algorithms of the ACE, American Association of Clinical Endocrinologists, how to start basal insulin. And we have to start with low doses, 0.1 to 0.2 unit per kilogram if the hemoglobin A1C is less than 8. And if it is more than 8, we are going to use higher doses, 0.2 to 0.3 unit per kilogram. This is for initiation, and then for intensification, you have to make escalation of doses according to the patient states. In fact, this is yesterday published. This is the endocrine practice, and this issue is this month's issue, and it is supplement. It is in June 2020. It didn't yet reach the market, printed paper, but it is printed online. This paper is a complete review of concentrated insulins and the clinical update of them and therapeutic options. We have spoken about the evolution of insulin all over the history from 1922 up to 2019. However, you can see that we didn't mention something like concentrated insulin. We have just mentioned 2GU and degludec, which are another sort of insulin. These are concentrated insulins, and they have different pharmacodynamics and pharmacokinetics, and they have also prolonged action, as you can see, with very small injection size. Looking to the left here, this is a comparison between insulin Lispro 200, which is again a concentrated insulin, Tresiba, which is 200, which is a concentrated form of Tresiba, U300 Glargine, this is 2GU, and we have 500 unit regular insulin, which is Humulin R, which are not yet in our market here. And look at the onset of action. The rapid one is the Lispro one, and then followed by Tresiba, and the Glargine starts in 6 hours. However, in only the Tresiba and 2GU, you can see that there is no significant peak. And this is very important for a basal insulin. The duration of action is exceedingly very good, very high. It amounts from 24 to 36 hours in the 2GU and almost 42 hours in the Tresiba. And this is one of the innovations that makes these concentrated insulin more suitable, more efficacious, more safe for the patients. And looking at their comment here for the real-world studies, they have a study here, very interesting study in UK. It's an open-label study, very recently published. They have tried to switch different patients with insulin to the glargine 300 unit. The patients were about 300, and they were type 1 mostly, and they were associated with clinically and statistically significant A1C improvements without significant changes in the basal insulin dose or body weight. Most important, body weight. Documented severe hypoglycemia episodes and diabetic ketoacidosis or hospitalization were low, and similar before and after DU300 glargine, which is 2G. And the German study reported that among 581,000 adult patients with type 1 or type 2, 7,000 of them receiving 2GU and 22 receiving 100 glargine. There was comparable A1C values, but there was reduced rates of severe hypoglycemia were seen in type 2 diabetic patients, but not in patients with type 1 using the 2GU 300 unit glargine. So if we look again to the comparison between the concentrated insulin 2G and its non-concentrated form and the Degludec 100, this is another brand, and looking at the comparison between these in type 1 patients, looking for the variability of its level all over the 24 hours. And the curve in the red is for the Degludec 100, and the curve on the green is for 2G. And you can see that the curve in green does not have any peaks if compared to the Degludec 100, which have a smaller peak that is 20%, leading to less variability per day. So the glucose infusion rate after a single injection of any of these have showed that the 2G is associated with 20% lower within day variability, as you can see from the slide. Again, as you can see here, all over the 24 hours, and dividing the day by quarters, you can see here the level of the 2G is uniform, whatever the time of the day. And this carries a lot of credibility to 2G. So let's go again to compare between the different basal insulins that are present in the market now. However, when we're going to compare any two drugs or two situations, we depend on the trials that tells us the difference between these brands or these compounds. And trials are either RCT, randomized controlled trials, or what we call real-world trials. What is the difference between these two types of trials? Looking at this question, and we got to choose one right answer, the comparison between the real-world trials and randomized controlled trials. Randomized controlled trials are the strongest evidence base, and this is true. It is number one. Most RCT trials can be achieved clinically. Unfortunately, this is not possible. Real-world trials are of low value as evidence base. No, they have their place and they have their value in conjunction with RCTs. Bias are frequently present in RCTs. No, it's not frequently present, but it can be very infrequently present. Both RCTs and RWTs are essential and complementary. Yes, they are essential and they are complementary to each other to know the difference between the comparable drugs. This is, as you can see from the left side panel here, this is the hemoglobin A1C in a real-world trial compared to the RCT trial, and you can see that there is an efficacy unrealized. There is a gap between the results here and there, and referring to the right panel here, you can see that there is a gap of 24% or something like that, and this was attributed to the conditions of the trial. The RCT trial are very, very restricted, and they very focused on the patient, the patient have an intensive education, intensive visit follow-up, and the patient is under the focus. While in the real world trials, the patient is left to his way of living and what he is doing every day. So that results in poor adherence sometimes, and also negligence, and there is a lot of missed doses and etc. Again, the real world trials provide information very important about the real life the patient living with. So it has a broader patient population because it does not have an inclusion criteria. It is for all of the patients that is concerned in the research issue. And it reflective of everyday practice. The limitations of the real-world trials it may be subject to several sources of confounding, such as missing data elements and other factors. However, they are very reflective of the real life of the patients and how they deal with the drugs and how they deal with the education. So to compare, we have trials looking for clinical pharmacology. That means pharmacokinetics and dynamics to compare Glargine 300 Toujeo versus Degludec 100. And they found that there is less fluctuating steady state pharmacodynamic profiles, lower within day variability in the Glargine arm, more frequently distributed pharmacokinetic profile in the Glargine 300, which is Toujeo. The trial series meta-analysis, and you can see that the begin and addition trials in type 2 diabetes comparing their effect in different situations. The IDEC versus Toujeo, there was less improvement in hemoglobin C in the IDEC arm, and the Glargine 100 arm, but with nocturnal hypoglycemia benefit in these studies. Again, comparing the Toujeo with the normal Glargine 100, there was similar hemoglobin C reduction and hypoglycemia benefit both at night and at any time of the day. The real-world trials involving the comparison between these are the DELIVER-D, and this included about 3,746 patients, and the Lightning trial including 130,000 patients. And they are concerned with switching to Glargine 300 versus the conversion to IDEC Deglera, which is the Degludec. The comparable improvement in glycemic control, there was a comparable improvement in glycemic control, and both have reduced in hypoglycemia risk. However, the rates of severe hypoglycemia were similar without compromising on the hemoglobin C reduction. The most important head-to-head trial was the PRIDE study, and this included high-risk population, including renal insufficiency patients, elderly patients, and included about 1,000 patients. And we are going to look more deeply in this trial. The trial included patients with type 2, more than 18 years old, and hemoglobin C was above 7.5. BMI was more 25 and less than 40. Oral hypoglycemic use plus GLP-1 at stable doses for at least 3 months. And an important thing, that is no prior insulin use. And these patients were titrated for 12 weeks, and then they continued the maintenance period titration for another 24 weeks. And the results were as follows. They compared the Glargine 300 once daily and the IDEC Degludec insulin 100 once daily. Let's look at the objectives of this study. This study was meant to be a non-inferiority study, just to show that there is no difference between both basal insulins, the concentrated basal insulins. This is the primary objective. And the secondary objectives were a lot. Hemoglobin C change, fasting plasma glucose change, fasting plasma self-monitoring blood glucose 4-point or 8-point profile, mean 24-hour plasma glucose over 24 weeks, variability, which is very important to measure, and percent of patients reaching the goal, hemoglobin C of less than 8 or less than 7, and percent of patients reaching the hemoglobin C 8 or 7, less than 8 or 7, without any confirmed hypoglycemia or weight gain, and patients who require rescue therapy over 24 weeks. Let's go rapidly here, and as you can see, this is at the end of the titration period on the left panel and the maintenance period on the right panel. You can see that the Toujeo in the green curve versus degludec in the blue curve are walking hand in hand in most of the time, and they have reached the same hemoglobin A1C level either during the titration or the maintenance period. So there is no marked difference here. And it was not significant, but the non-inferiority here was significant. There is no superiority, but the non-inferiority measure was significantly very, statistically very significant, as we can see here. لما نيجي احنا to give our patients insulin to start with, what are the factors you most concerned with when prescribing basal insulin as initiation in a patient? Do you care for the rapid reduction of fasting plasma glucose? No. This is maybe deleterious. It has no advantage to reduce the fasting plasma glucose very rapidly. Are you caring for rapid reduction of hemoglobin C? No. You have at least 3 months to go for a reasonably reduced hemoglobin C. You care for rapid reduction of weight? No, of course. We are looking for weight neutral. We are giving anabolic hormone, which helps increase in weight. So we are looking only for the weight neutral. Are you looking for very low rates of hypoglycemia? Of course. This is a very major safety issue. If the patient in initiation experiences hypoglycemia, he will stop the insulin and he will hate insulin and he will never go to use parenteral therapy for diabetes. Flexibility of administration and dosing is very important, of course, but it is not the major concern when prescribing our insulin. This is a BRIGHT study, and you can see that anytime hypoglycemia during the titration phase was in favor of Toujeo. There was 43% reduction in hypoglycemic events during the titration period, which is very important for these patients to continue their insulin and become persuaded of the value and the effects of insulin. If they have an increased rate of hypoglycemia during this period of titration or initiation, they will stop using insulin, for sure. Again, for the maintenance period, there is again 19% reduction in favor of Toujeo. You can see here again that in the full study period, overall there was 31% reduction in hypoglycemia in the study period. Looking for the nocturnal hypoglycemia, which is very serious. The patient is sleeping, he cannot feel the hypoglycemia, and he can die in bed due to severe hypoglycemic episode while he is not aware of it. So nocturnal hypoglycemia is a major concern in insulin-treated patients. Looking for the difference between the two drugs here as as long as nocturnal hypoglycemia is concerned, we have 35% reduction in nocturnal hypoglycemia in the 2GU arm. In the maintenance period, you have again 4%. However, the whole period, the full study period, showed 19% in the nocturnal hypoglycemia. Those patients who achieved the target hemoglobin A1C in the BRIGHT study were 24% more than patients in the degludec arm. This is the degludec arm. 13.6% of the patients using this drug have reached their target without hypoglycemia. In the 2GU arm, 16.9% have achieved the target without hypoglycemia. And the difference here is 24% reduction in comparable, and this is means a lot. This is an article also about concentrated insulins, and this had been published very recently also. And when they switched the patients using basal insulin from any other basal insulin to degludec, they have shown that after adjusting for baseline confounders, patients who switched to 2GU were 34% less likely to discontinue their basal insulin than patients who switched to other basal insulins. Patients who switched to 2GU were less likely to experience hypoglycemia at 3 months follow-up and 6 months follow-up. So this goes in accordance with the BRIGHT study. Two more things before we close, that the renal patients and the elderly patients in the BRIGHT study were examined very carefully, and they're very important because the most of these patients in the study, 38% of them have some sort of chronic kidney disease, and for type 2 diabetes, and 20% in type 1 diabetes. And these patients are very exposed to hypoglycemia risk due to the impairment of the renal function, leading to less insulin secretion and inability for gluconeogenesis and glycogenolysis, and this carries a cardiovascular risk. That's why they were examined very carefully in the study. Here is the comparison between the two arms of degludec and 2GU in the patients here, and the mean hemoglobin A1C was achieved in the 2GU arm more than the other arm by 32%. And again, with no difference in hypoglycemia. This is very important. You can reduce the hemoglobin A1C by a lot of means, but it should be without hypoglycemia or excessive weight gain. And this is what have been observed in the patients with chronic kidney disease. Again, in the elderly populations, 26 of the patients under study have aged more than 65 have diabetes, and these again are exposed to high rates of premature death, cardiovascular disorders, functional disability, and comorbidities, and they are great risk of hypoglycemia again, and for depression also. And you're looking at the results of the BRIGHT study in patients over 70 years old using the Tresiba versus the 2GU, and you can see that they have achieved 26% have achieved the target of hemoglobin A1C within 24 weeks more in the 2GU arm versus the degludec arm, and again that was without hypoglycemia over 24 weeks, as you can see from the right panel here, where the Glargine 300, which 2GU have showed very similar results to the degludec. So, in summary, in conclusion, basal insulins, specifically the Glargine 300 2GU, are a novel and next generation insulins for treating patients. 2GU have proven to be more stable and have a prolonged activity profile beyond even 24 hours. And this means a lot for patients who are using the 2GU. They have an even and smooth 24-hour distribution of glucose lowering activity. So there is no peaks, and subsequently, there is no hypoglycemia. They have 20% lower within day variability with glargine 300 versus teglodic 100. They have more stable pharmacokinetic profile versus the deglodic. They have less risk of post-nocturnal at any time and anytime hypoglycemia versus Tresiba in the titration period, specifically in the titration period. They have greater hemoglobin A1C reduction without increase in hypoglycemia and without increase in body weight. So this concludes my presentation, and I hope that I have cleared that the basal insulins are essential in the treatment of type 2 diabetes and type 1 diabetes. They are more safe, innovated basal insulin, and they have proved their efficacy along these trials. Thank you for your presence here.
Thank you, Dr. Nabil, for reviewing this important topic. And now we'll call all the speakers for the discussion. So we'll start with Dr. Khalid. The first question, if obesity is a disease, then an obese patient is susceptible to COVID-19. So, Dr. Khalid, please, your comment.
Hello?
Yes, Dr. Khalid, Assalamu alaikum.
Alaikum assalam wa rahmatullah. Yes, for the chance of getting the infection, COVID, obese patient, I think like other chronic disease, they have the same chance of getting the infection. But for the complications or getting serious complications secondary to the infection, yes, the obesity is one of the highest comorbidities that might lead to serious or severe complications with COVID. And it is on top of mortality, the common comorbidities in people died with COVID. So there will be high risk of mortality, morbidity if he is obese, especially with as the BMI increasing. But the chance, it's like diabetes, like other chronic diseases, the chance of getting the infection is equal. But the immunity for sure and the complications more with patient with obesity.
Thank you, Dr. Khalid. Question to Dr. Hussein. How effective is a liposuction as treatment for obesity? Dr. Hussein?
Very interesting question. So liposuction is a cosmetic procedure. It's not considered a treatment for obesity. It doesn't have any metabolic advantage. And therefore, it's not considered a treatment for obesity.
Okay. Thank you. Dr. Asim, Prof. Asim. So what's your opinion about ketogenic diet as a way for weight loss, and why is not popular?
Okay, thank you for the question. Very interesting topic. I'm not as specialized in nutrition, so I'm sure you will have sessions on that. But from my experience, it is one of the tools that could be used in treating overweight or obesity for a certain period of time. The literature right now is going very rapidly in this direction, showing the advantage of this type of diet for the short term at least. Now, for the long term, we know that it has its own complications because it lacks a certain amount of fibers, and because of the high protein, high fat content, it could affect the cholesterol and lipids profile in these patients, and also it could be affecting the vitamins in some of the patients. So we don't usually use it as a long-term treatment, but I cannot say that it is not beneficial for short-term. Some of the patients under clinical observation would benefit from the certain type of diet, but it should be under observation by their physician.
Do you think for long term, is it effective or just for short period?
Well, long-term data showed that it will become almost similar to the weight loss that you would obtain with the usual healthy diet or healthy food, because you will have rapid decrement in the weight with the ketogenic diet first 6 months, but then the weight might increase gradually, and then you will not have that difference between both diets, the regular diet and the ketogenic diet, in some early studies. So I don't think for the long term it would certainly do much. I have some patients on it already. Some of them, few, would be able to continue on it for long term. But as soon as you start to go to the regular diet, they will start to regain some weight. So I don't recommend it for long term because of its complications. But for the short term, I think it could be used under clinical supervision.
What about using it for diabetic patient? Do you have an experience?
Well, diabetic patients, some of them who used it, they were really happy about it. I mean, as you know, they decrease the use of insulin, the medications will also you decrease the doses, and they might benefit a lot from it. And there's data on this already. We know there's data on this. So I think we should be open-minded for any type of diet. If we can really observe the patient on it and make sure there is no contraindication, no kidney problems, and the patient could tolerate it, I think it could be tried in some patients. So I don't support the idea of just blocking all these type of diets. No, some of them are still going to be good for some patients.
Thank you, Prof. Hassan. Dr. Nabil, can we use insulin to used in patient less than 80 years of age?
Yes, we can use it in patients with type 1 diabetes, less than 18 years, and 18 years was in the criteria of inclusion in the BRIGHT study. But in real world, you can use it as a basal insulin for any patients needing insulin. With a type 1, but for type 2, it carries a risk here that the patient may be type 1. So you should be that those patients who are using basal insulin with age less than 18, this may carry a risk that they have type 1, and you should combine it with other types of insulin as a basal bolus or something like that to cover their needs of insulin. So above 18, you are about to be more likely that he is type 2. So basal insulin plus oral can be used at that time. But if it is type 1, you should combine it with rapid-acting insulin.
What about children less than 12 years or 10 years?
Yes.
Okay. Dr. Khalid?
Yes.
For patient on antipsychotic medication, what is the best intervention after diet and exercise?
Antipsychotic medications. Antipsychotic is the question?
Antipsychotic, yes.
Yeah. If patient under antipsychotic medications, there are few of the antipsychotic medications can cause weight gain. On top of them, olanzapine, Zyprexa. So if there will be another option to be switched on, that would be a good option. If there is no option to be switched because some patients only responding to certain medications. So at this time, I think you have a patient will be taken to what's called MDT groups or multidisciplinary sessions to be following with the medical, surgical, nutrition, and psychological sessions on like more frequent sessions. I would recommend him to be like in a high risk group for gaining weight, to be seen by multidisciplinary team and frequent scheduled visit. But if there is option from the point of psychiatrist to be switched to another medications less on weight gain, that will be a good option. Yeah.
Thank you, Dr. Khalid. Dr. Hussein, some patient, of course, lifestyle modification is very important for treatment of obesity, but some patient losing weight in many lifestyle is impossible. So the question is, when at what level of BMI we should think about the treatment or medications?
That's an excellent question. So weight loss medications are indicated for patients who have obesity meaning BMI more than 30, or BMI of 27 if they have comorbid conditions. So in Saudi Arabia, we only have 2 approved medications by the Saudi FDA for weight loss: liraglutide, Saxenda, and orlistat. So after patient is properly evaluated, especially by multidisciplinary team clinic, and already optimized on diet, exercise, and we roll out other causes of obesity, then weight loss medication use is indicated.
So what about surgery, bariatric surgery?
Yeah, so surgery is a choice for patients with higher BMI. So patients with a BMI of 40 and more, or 35 with comorbidities. It should be considered for patients with lower BMI if they have, let's say, like uncontrolled diabetes. So even class 1 obesity could be considered for bariatric surgery.
What about bariatric surgery for the children?
So I think we are learning more about it now. We have more data for the children. So this is considered for individual cases. But it's being now, I think, especially in Saudi Arabia, we actually have more data about using bariatric for the children population.
Okay, thank you very much. Prof. Asim, what is the rate of suicide in obese?
Well, I'm afraid I don't have number on the rate of suicide, but as I previously mentioned by the speakers that there is a high correlation between obesity and all the psychological complications, but I don't have any number on my head on this.
So what is the problem now? We said the problem in obesity is the awareness from the physician point or healthcare worker and the patient and different. So what we should do, or what was action we should have it to improve this?
Yes, very good question. So as you said, the perception of obesity is not that it's not optimal, both in terms of how patients look at obesity as a problem. It is a disease, and we should make sure that we educate our patients about it as a disease. So, for example, if they improve on an intervention, they should continue this intervention to control the disease for a long time. They should not stop the treatment because they will improve on this treatment in the short term. In physician also, we should make sure that they understand the biology of obesity. It is a complicated hormonal metabolic disease that would need long-term follow-up, would need different modalities of treatment, lifestyle, diet, medication, surgical. All these tools could be used in several conditions for several patients. Some authors even compare obesity like a cancer. So in cancer, you have many things to do. You need to give medication, sometimes you do surgery, sometimes you do radiation. So again, obesity is a recurrent relapsing disease that you need to make sure that you follow, you make sure you don't stop following these patients because they might regain again the weight. You should support them psychologically. You should make sure there has no complications. So deal with it as any chronic complicated disease with, first of all, diagnosing this problem, make sure you have proper follow-up and referral in these patients for any specialty you need, and make sure the patient have enough support during the course of this disease.
So do you think we need a campaign for the patient awareness?
Yeah, well, campaign is one important point, and then I think education. Well, I think early we can put obesity in our education programs, the better, during schools, elementary school, primary schools, secondary schools. So people think about healthy diet. They don't look about diet as something that would restrict people from eating what they want, but focus on healthy diet, something that they need to make sure they use and they avoid the unhealthy diet like sugary beverages and all this high sugar content diet and drinks. So try to make them aware at an early stage so that they adapt this healthy lifestyle in their life.
Thank you, Prof. Asim. The last two questions for Dr. Nabil. In obese patient with type 2 diabetes, what is the best drug for choice to control blood sugar?
Of course, GLP-1 agonists, receptor agonists, are the best to control the blood sugar and to reduce weight. And as Dr. Hassan just mentioned, the liraglutide, or Dr. Khalid, I think, one of the Saxenda, one of the important drugs used in that matter. However, there is also a new drug which is called semaglutide, which is the Ozempic one, which is another GLP-1 agonist that works more effectively on weight. So the use is associated with considerable weight loss, together with high efficacy in controlling diabetes.
Thank you very much. Actually, in view of time, we have a lot of questions, but because of the time, we have to conclude here. Thank you for the all speaker and for the audience. And just a reminder, there will be 20-minute break, and then we'll start the second session. Thank you all again, and see you, inshallah.
Thank you, Dr. Tariq.
Be safe.